Hi, everybody. Dr. Becker. We are going to start with Chapter 9 now, Circulation, Part 1 of the series. This chapter and the next chapter, which is heart. So we start with circulation and the vascular portion, and then the heart portion in Chapter 10, I think are very heavy chapters with lots of content that are very foundational. These seem to be concepts that you're going to see every day in practice. And so it's, I think might be helpful for us to walk our way through them together. So the book, instead of doing cardiovascular together in TACs, they split it between vascular/circulation and then cardiac is chapter 10. The reason that this is going to be so important is because cardiovascular disease is a major cause of morbidity and mortality in the United States and worldwide, really. Talking about your circulation and your vascular system is important because these are things like blood pressure, and blood pressure is something you get at every doctor's appointment, right? Every hospital stay, you're getting your blood pressure done multiple times. The cardiovascular system is affecting almost every disease state to some degree or another. So understanding the physiology is very important so that you can understand then the pathophysiology. The key concepts that they're going to walk us through here are listed here. They break the blood vessels down by kind of these 4 different types: the large arteries, the small arteries, the capillaries, and then the different parts of the venous system. These are some of the disorders that are associated with the different systems that we're going to talk about. So if we're speaking of large arteries, we want to understand the physiology. So that can help us understand the pathophysiology of atherosclerosis and aneurysms, peripheral arterial disease, genetic disorders like familial hypercholesterolemia. When you're speaking of the arterioles, we're thinking things of blood pressure and shock, all forms of shock. Capillaries, disorders that cause edema or increased capillary permeability, are going to be affecting the capillary system. And then the venous system, if we have disease states there, it's varicose veins, venous thrombosis, venous insufficiency, and venous ulcers. When you talk about the circulatory system in general, what does the circulatory system do? Why do we have it in the first place? What is its purpose? And obviously we know that the circulatory system is meant to be a highway, essentially, a transport system using blood as our vehicle. And through that, we can deliver throughout the body the fluids, the nutrients, the hormones, the oxygen, all those things, and we can take waste away to bring back to the organs to get processed and to be excreted. That's kind of the simplest form of how you say it. So in the circulatory system, we have where we are going to receive the cardiac output, where the blood enters the system, and that's pumped into the arterial tree. Then that blood circulates, it delivers oxygen and nutrients to the tissues, removing our carbon dioxide and our other wastes. The endothelial lining produces vasodilators and constrictors, which contributes also to clotting. The circulatory system carries our hormones from the endocrine glands to the target areas. The circulation helps perfuse our kidneys, which helps initiate the glomerular filtration. We have to have a functioning circulatory system for our immune function so that we can transport our white blood cells, cytokines, those things. Your circulation has to respond to tissue metabolic demands, and the circulation system is under both autonomic and hormonal control. So our body has built-in mechanisms of how to manage our circulatory system in the response to our needs. To review, remember that the heart has the 4 chambers and it works as a dual pump. So we create systole and diastole. So simultaneously we're pumping blood in both the cardiovascular circuits. And when they talk about the circuits, they're referring to our pulmonary circuit and then the systemic circulation. So these 2 circuits are coupled in parallel So our total blood flow, which is our cardiac output, is the same in both systems. When we talk about how we move the blood through the circulatory system, we call that flow. So the flow of the blood requires pressure. Blood will always flow from regions of high pressure generated by the ventricles to regions of lower pressure, respectively. The biophysical principles that we talk about now moving forward is focused on flow and pressure to have as concepts we have to understand the vascular structure, function, and when we become vulnerable to disease. This image here is a nice one because it shows the two circulatory circuits. And if you follow it here, the starting with the arterial system, we know that the left atrium receives the blood that's oxygenated from the lungs. Left atrium dumps into the left ventricle. The left ventricle pumps through the aorta, and we have our ascending aortic arch and our descending aorta. And as it goes through, it branches off into all the arterial tree. Ultimately, we are supplying blood supply to our upper body, our organs, including the liver, stomach, intestines, renal arteries, the kidneys, all these things, and then the lower half of our body. Down at the tissue level is where the capillaries interact with the tissues, and the venules bring back the waste, and they will dump it back into our venous system. So all the organs also have a venous system to dump it back into the inferior vena cava, which carries it up to the superior vena cava, to dump back into the right ventricle or right atrium, to dump into the right ventricle, and then take that to the lung. Here we'll get rid of our carbon dioxide and we'll pick up fresh oxygen, and the circle keeps going and going. Remember that the pulmonary artery is a very important part of the body as well. So the primary goal of our pulmonary circulation is to oxygenate the blood and remove the CO2. So 100% of our cardiac output flows through the lungs. Typically, per minute, we have about 5 liters flow per minute. The oxygenated blood is returned to the left atrium by means of the pulmonary vein. The pulmonary vein is the only vein that carries oxygenated blood. Every other time you have a vein, it just probably contains unoxygenated blood. But the pulmonary vein is the only vein that carries oxygenated blood. Whereas also the pulmonary artery is the only artery that has unoxygenated blood. Now remember, the flow, the volume, about 5 liters per minute, matches between the pulmonary and the systemic circulation. However, even though they have the same amount of total blood flow, the pressure and the vascular resistance are about 5 to 10 times lower in our pulmonary circulation compared with our systemic circulation. So in other words, the pulmonary circulation has a much lower pressure and vascular resistance. When we talk about our systemic circulation, remembering that it's running parallel at the same time to the pulmonary circulation. The distribution of blood flow through these circuits will dynamically adapt to our metabolic needs, right? Which leads us to this here. At rest, the kidneys, the GI system, and the skeletal muscles each receive about 20% of the cardiac output, while skin blood flow is only 4 to 5%. Okay. So it gets very little flow to the skin at rest, okay? But during exercise or stress, so fight or flight, right? Anytime we're exercising and all of a sudden increase in our metabolic demands, cardiac output, skeletal muscle, and then the skin blood flow will increase greatly. But then during exercise, our renal and GI system, for example, will decrease. So the body knows how to redistribute the blood flow because it's an adaptive mechanism to make sure that the areas with the greatest metabolic need is increased during our activity. The vital organ of our brain pretty much gets the same flow no matter fight or flight. So it's adequately perfused at all times. The book then jumps into talking about the structures and the properties of our blood vessels. So if we think about it, the structure of our vasculature becomes very important for us to understand the physiology of how it typically works so that when we have a disease state, we understand where things have gone wrong. When we're talking about the wall composition of the vasculature or our circulatory system, we have to think about vascular compliance, the recoil, and the permeability. Your book does a really good job, I think, of this, and your videos through osmosis as well does this quite well. All of the blood vessels, except for the capillaries, will have a 3-layer structure. The inner layer of the vessels is the tunica intima, and that then, if we look at that here, this is what we're talking about here with our intima, okay? This in and of itself, the intima consists of 3 layers, which is a single layer of the endothelial cells, which is the interior lining. Then you have the basement membrane, but then you have the layer of elastic fibers, the elastic lamina, as you can see here. The endothelial cells play a very crucial role when we're talking about maintaining our vascular health, especially in our larger artery systems. The endothelial cells then also play a role in regulating the vascular resistance, and they play a huge role when we get down into the arterial and capillary bed. Folds of the intima in the limb veins form one-way valves that are essential in facilitating our venous return. Okay. Our middle layer then is the tunica media, or just the media, and that is mostly composed of concentric layers of vascular smooth muscle, which is the VSM noted here. Changing contractile activity of the vascular smooth muscle is the primary mechanism of our second-to-second regulation of our arterial resistance and our tissue blood flow. Outside of that smooth muscle, the vascular smooth muscle, is another layer of elastic fibers called the elastic or the external elastic lamina. Then the outermost layer is the tunica externa or adventitia, and this is composed of the strong connective tissue that helps keep our blood vessels intact. Okay, so between the inner, middle, and outer layers of our vasculature, all of these are going to be important for us to be able to do our job, quote unquote, of the vascular system. So the wall composition is what helps us to determine our vascular compliance, our recoil, and our permeability. It's our vascular smooth muscles that help determine contraction and relaxation, and that determines our vessel diameter and our vascular resistance. And it is that helps us regulate our blood pressure. We know this, we've said this, the aorta and the pulmonary artery will branch into the smaller arteries, the arterioles, and then the capillaries. The postcapillary venules converge and they end at the vena cava and the pulmonary veins. The capillary walls are that single endothelial layer thick, have pores, and they optimize the exchange function. So that's what they're referring to down here. This is a single layer of the endothelial cells, which are very porous. And this is then where we have this nutrient and gas exchange. And then it's connected to the venule system, which again is a smaller here. And then as it goes, it grows to create these bigger reservoirs so we can keep about 60% of our blood at any time is pooled within our venous system. And this is what we talked about there. I do want you guys to understand what these inner layers are. Obviously, at the inner layer, that's where we're going to have the endothelial cell, where we can actually have the blood interact with the tissues. The middle layer is the vascular smooth muscle, and the outer layer is connective tissue. So the first section, remember, we're going to talk about large arteries, the other arteries, the small arterioles and capillaries, and then the venous system. So starting with the large arteries, one of the first things to understand is that they have three main functions of our large arteries. And this is obviously to deliver blood from the heart to the tissues. We also need to distribute blood flow to the multiple parallel circuits of the systemic circulation. And we need to maintain blood pressure and blood flow during diastole. So we're going to talk about these. Your book talks about briefly the law of Laplace. There is a video in Osmosis. If you haven't listened to that, I would stop and listen to that to make sure you've reviewed with them. They do an excellent job of talking about it. What they're talking about is that we have to have tension within our vascular system in order for this whole system to work and not have circulatory collapse. The tension is what keeps the vessels open during diastole. Diastole is that brief period where we don't have any force. We have no blood forced coming through because it's at a period of rest. The law of Laplace then talks about this because it takes the definition of tension is created by the pressure in the blood vessel times the radius of the blood vessel, and then divided by the thickness of the blood vessel. And so this is how we get the idea of how much tension is in the artery. High pressure and a relatively large radius of the arteries increases wall tension, but that's counteracted by their greater wall thickness. Okay, so this is important to understand because when you have uncontrolled high blood pressure, you are going to greatly increase your wall tension and the vessel walls hypertrophy in response. If arterial walls weaken due to like atherosclerosis, the wall tension then actually helps form these aneurysms, which we know is poor. I like this image here. It makes sense to me. The wall tension is exerted around the circumference of the vessel, right? High wall tension promotes the aneurysm formation, though, and rupture, which is a bad thing. But what we're showing here is that this is the pressure being exerted by the flow. This shows us how wide the diameter is, and then how thick the vessel wall is what we'll get our formula to determine tension. Because our arteries have to withstand such high pressure and a large radius to control, or because they need to be able to hold a large volume of our blood, like our aorta is large in diameter, and it's going to have a lot of flow and pressure from the left ventricle. It has to be able to handle that, so it's going to have a thicker vascular wall. The worry, though, is that if that becomes fibrotic or diseased and you get an aortic aneurysm, well, now we have a troublesome thing, right? So if you think about it, anything that we do that manipulates these variables, we may manipulate the tension. So if we have the H being the thickness of the wall, if something causes vascular hypertrophy and this becomes even thicker, by the basis of this, we may alter our tension, right? So the increase in our wall thickness helps to offset the effect of increased pressure and decreased wall tension. So we do have vascular hypertrophy as a compensatory mechanism for increased vascular pressure. But if the increased blood pressure, right, so over time, the increased pressure, which in essence is our blood pressure, to compensate for that, they're going to increase this, remember, because if we make this number bigger, we create lower tension. So if our P is our pressure, so our blood pressure is going up and up and up and up and up, meaning our tension's getting higher and higher and higher. To offset the P, the body will create vascular hypertrophy. So if we make the H a bigger number, T is going to go down. So it's our way to compensate. The problem with that is that over time, the thicker the vascular wall becomes fibrotic, it can lead to these other secondary problems. Think of arteries that lead to our renal system. So over years of high blood pressure, we can get renal artery stenosis. We can get, because of this whole problem with too much pressure, it alters this law of Laplace, and now we can get renal artery stenosis, where because we get this vascular hypertrophy and the pressure and the response is this actually becomes hypertrophied and it encroaches in and creates a stenosis of the renal arteries, decreasing our blood flow to our kidneys and causing hypertension-induced renal injury. So understanding this concept of the wall tension, the pressure, the radius, and the thickness of the vasculature is really important to understand how those alterations of any of these variables here are going to cause disease states later on. Functional properties of the circulation. So let's review these again as they write them out here. Pressure is pulsatile in vessels all the way down to the arterial level. And we'll get a graphic here in a minute to help us explain that. There's going to be some pulsatile pressure in our large arteries, our medium arteries, and arterioles. But by the time we get down to the capillaries, we've lost the pulsatile pressure. Okay, so we'll talk about that. Flow is continuous along the vasculature. There's always blood coming through. Pressure and flow follow some of these biophysical principles. The flow occurs from areas of high pressure to low. Flow is inversely proportional to resistance. Okay. So if you have high resistance, you're going to get low flow. Flow velocity slows as the total diameter increases. So it's slowest in the capillaries. The blood exerts outward hydrostatic pressure on the vascular wall. Hydrostatic pressure also depends on wall compliance, which is greater in our veins than in our arteries. Anything that is flowing past a wall, like on a vascular structure, will create a frictional shear stress. Okay. So these ideas come into play then as we're talking about other disease states. So first we talk about the idea of vascular compliance, because the vascular compliance then influences our volume and our pressure relationships. So this image here is obviously the left is the pressure of the venous system, which is blue, unoxygenated blood. On the right, they show us an arterial pressure. So hydrostatic pressure is exerted by the blood that's pushing outward on the vessel. That is influenced by wall compliance. Okay. A very compliant vessel can hold a larger volume at lower pressure. So to me, our venous system reminds me of a really stretched out water balloon that I, hook up to the hose. The minute I turn that flow on, it is very compliant. It loosens quickly and it very quickly, fills up with water in that water balloon. So very quickly, it can hold a large amount, even with low pressure coming through the faucet. But if I have a really stiff balloon that hasn't been stretched out at all, and it's really tough and not stretchy, and I hook it up, even if I turn on great flow, that's what it's going to take, is a much greater flow to force that open. But it's just not as stretchy, so it's just not going to open all the way because there's less compliance. So a less compliant vessel will hold a smaller volume at higher pressure. The other thing to remember is that even though the venous system is more compliant, the arterial system is more has greater elastic recoil. So it has a stronger and faster coming back to its position. I'm making gestures with my hands right now, and I know you guys can't see that, but it'll be explained here in a little bit. So to understand compliance, it's important to understand that compliance is a way to describe the ability of a three-dimensional structure to stretch. Remember, when we stretch, we increase in volume. And oftentimes we need to stretch in order to take in an increased volume as a response to increased pressure. The book says it's much easier to blow air to inflate a more compliant party balloon than it is to pump air to fill a less compliant bicycle tire. That's a good description. So the book does talk about the formula of compliance is actually the change in the volume divided by the change in the pressure. So all blood vessels stretch under pressure, but to different degrees. Okay. The arteries are less compliant than the veins, but the arteries are subjected to greater pressure changes as they receive the stroke volume of the heart during systole. The aorta and the large arteries contain those abundant elastic fibers that are needed for the arteries to stretch during systole, but we also need them to return to their original shape during diastole. So the ability to recoil that the large arteries have is what helps maintain our diastolic blood pressure, and thus we get adequate tissue perfusion between heartbeats. So it has to be able to recoil and come back together to continue to push the flow for that brief moment at rest when diastole stops, or at diastole there's a moment where there's no pressure coming because there's no squeeze. It's at pure rest. And so the arteries need to be able to come back together this way in order to continue to push the flow down so that there is movement going even during diastole. When we age, an age-related change is often something that causes some disease states like atherosclerosis, but over time, often our arterial walls become less compliant. So that's a problem because that will lead to an increase in systolic blood pressure, but it will lead to the decrease in diastolic pressure and blood flow. So what are we talking about there? Okay. This is what they're trying to say. The ventricle ejects stroke volume into the aorta and the large arteries. So you're going to get systole here. So we get this squeeze of the ventricle. We're going to eject into the arterial system at high pressure, right? So if my blood pressure is 120 over 80, right? At this 120 degrees of mercury, millimeters of mercury of pressure are going to come through this arterial system. So that is going to force expansion of the artery wall, right? So it's going to expand to take the volume, but it's not super compliant, but it's enough compliant to expand and stretch. So we get a systolic peak pressure here in our arterial system. The elastic recoil promotes diastolic pressure and flow after it closes. So right here, even though that closes and we're in diastole, so there's this moment that this is closed and this has reached its maximum fill. So this moment of the end of diastole, the ability of the wall to come snapping back together and recoil is what finishes propelling more blood down flow, so that even though there's no pressure coming, this movement creates enough pressure to continue the blood flow onward So all of our arteries continue to have flow through them, and we continue to perfuse organs. So this is why this should work correctly in a normal physiological state. But let's say, like we talked about, you get vascular hypertrophy. We said that would be like maybe with years and years of high blood pressure. So we get these stiffer arteries. So now look, we've lost this elasticity to be able to push outward, right? So the blood's still going through, but now it's having to be forced through even a smaller diameter, which is a kind of a negative feedback, because it's going to continue then to up and up and up the pressure. So now my blood pressure's 180 because I have to create a lot more pressure to force through this non-compliant wall. But now what happens is that I've lost this recoil, right? So now at diastole, this is shut, and at the end of diastole, there's a period where there's no more flow coming. So this is actually going to show we're going to have a significantly less diastolic blood flow, less pressure will be coming through. So with aging, it will increase our systolic pressure, but it oftentimes will reduce our diastolic blood pressure and flow. So you're going to see a greater difference between your systolic number and your diastolic number. And when that happens, that's probably telling us that we've lost vascular compliance as one of the reasons that we see those changes in pulse pressure. Veins are much more compliant than arteries, so that makes them ideal to serve as our blood reservoir. We call that capacitance, where they can have the capacity to hold 60 to 68% of our circulating blood volume is stored in that at a low pressure in our veins and venules. Next concept to talk about is the biophysics of our blood flow, our velocity, and our shear stress. This is another thing that leads us into a lot of really get into the biophysics, right, of having to open up our minds and understand how this works. So our large arteries are going to branch into our smaller arteries, our arterioles, and our capillaries. So the total cross-section area at each of these segments becomes greater. The blood flows into many more channels, so that lowers the velocity of the flow in those segments. Blood velocity is highest in the aorta and the large arteries, and then the velocity is much lower in the capillaries. We have to understand blood flow velocity because it's directly related to shear stress. So that is the friction of the blood as it's sliding past and pulling on that endothelial cell surface with the direction of the flow. Slow blood velocity is also the foundation for capillary function, as those vessels are the regions of exchange of water and our blood-borne substances between the blood and the interstitial fluid. We call it laminar flow in a large blood vessel because this is referring to layers of the blood traveling smoothly parallel to the long axis of the vessel, with the blood flow in the middle having the greatest velocity. This honestly makes me think of the lazy river. If you've ever been on a lazy river in your little float device, if you stick to the middle, those people oftentimes are moving faster than those of us that stick to the outside and kind of bob off the wall and aren't going to go as fast. This is what they're talking about. The flow in the middle is going to have the smoothest because it's not being bumped against the wall, is essentially how I would say that. So laminar flow is this one in the middle that's flowing smoothly. This type of blood flow is low vibration and it's highly efficient. Your book says, picture the blood slipping smoothly past the endothelial cells lining the blood vessel wall. With smooth laminar flow, there will be little friction between the formed elements of the blood, the cells and the platelets, and the vessel lining. However, we lose laminar flow and we get turbulence at narrowed areas and at branch points, which is what they show us here. So we may be having some nice normal flow, but all of a sudden, we hit, and now our flow has to change and be disrupted. Turbulent flow causes vibrations at the vascular wall, which is why we can hear a bruit. So if you hear a bruit, you are hearing turbulent blood flow. Not a good sign. Normally, our laminar flow and high velocity in our large arteries can still cause shear stress. So because they're still flowing fastly, you can still get a tugging force on that endothelial layer that lines the vessel. Hydrostatic pressure further acts on the vessel wall by exerting a perpendicular distending force that contributes to wall tension. Okay. So that's, get rid of my ad. That is what this is trying to show us here. Okay. This is our endothelial cell wall here. So mechanical forces acting on the endothelial cells are going to include longitudinal shear stress. Okay. Just over time, the blood does eventually rush past, so we get shear stress. And then we get the presence of smooth laminar flow, which is good. And then we can get these biochemical and biomechanical factors that influence our endothelial cell production of our paracrine and our autocrine mediators. And then we also have our smooth muscle contraction part. So let's kind of put this better together. So it's normal to have this shear stress. We have hydrostatic pressure, then that helps exert a perpendicular force that contributes to our wall tension to keep the vasculature open. In response to those forces, the endothelial cell and the smooth muscle layers generate and respond with a variety of biochemical mediators. Okay, the most important mediator that we start talking about in the vascular system is nitric oxide, and this is released by the endothelial cells, and it diffuses to the underlying layer of our smooth muscle layer here, smooth muscle cells, and this is what helps control vasodilation, maintaining vessel patency, and then also it's important in our vascular wall health and to lower the blood pressure. So we have to have normal, good laminar blood flow, okay, with these biochemical and then our biomechanical factors at play. This helps keep a healthy endothelial cell, which can then release the mediators that we need, including nitric oxide, to cause vasodilation and have the function of the vascular wall. Okay. However, during disease processes, altered shear stress due to turbulence or atherosclerosis, like here. So now all of a sudden it was all fine and dandy, and then we hit this is atherosclerosis. So now we have disrupted this nice smooth laminar flow, and we're in trouble because the altered shear stress due to atherosclerosis or anything that causes turbulence or other chemical mediators, this is going to disrupt this beautiful system we have here, and it disrupts the nitric oxide production and disrupts our normal vascular signaling. Okay, so we have a problem. Also, vasoconstriction and BP elevation can result from this altered vessel wall signaling. Right, so this really screws things up when we have atherosclerosis. But they're talking about here about downflow, we may have low shear. So what happens is that in areas of turbulent flow that we've created here, downstream from that, where we branch off downstream, the endothelial shear stress is reduced, and this then, because we need to have this normal shear stress and this pressure to stimulate our endothelial cells, which then is what happens to help us make the appropriate levels of nitric oxide. So in here, we've lost that shear stress. It's gone down. That is going to lead to decreased nitric oxide production. When we get the decreased endothelial nitric oxide production, then this is the signal that leads us to know we have endothelial dysfunction, and that endothelial dysfunction contributes to and accompanies atherosclerotic disease. Okay, so this is a problem from atherosclerosis as well. And then it's kind of a catch-22 because regions of high shear and turbulence at these branch points may also sustain endothelial injuries that's going to promote actually more atherosclerosis formation as well. So it's a double whammy. During high blood pressure, however, increased blood pressure causes elevated shear stress with the background of endothelial dysfunction and nitric oxide production's decrease. So in that case, the elevated shear stress cannot increase nitric oxide production. It rather contributes to endothelial damage and then continues to exacerbate atherosclerosis because we damage the endothelial cell wall. Atherosclerosis is the first disease process we're going to talk about of the large vessels. So atherosclerosis in our arterial system is a problem, or in any of our arteries, but in the large arteries, okay, arterial disease are the most common, and there's two typical presentations, which is the atherosclerosis and then the weakening of the wall leading to aneurysm. The most common sites of atherosclerosis in order are the abdominal aorta, coronary arteries, thoracic aorta, femoral popliteal arteries, then our carotids, and then our vertebral, basal, and middle cerebral. The definition of atherosclerosis is the buildup of plaque within the walls of large conduit arteries, and it's a chronic inflammatory disorder of the vascular wall. The interesting thing about atherosclerosis is that it does tend to begin in humans in adolescence and early adulthood. Atherosclerosis is typically the root cause of coronary, cerebral, and peripheral vascular disease. Okay. Understanding atherosclerosis is really important because it also leads to understanding why we use certain medicines and how they're going to be effective. So down the road, when we get to pharmacology, we'll be able to remember back to this, understanding the formation of atherosclerosis. Okay. It's actually a chronic inflammatory response to accumulation of our low density lipoproteins in our cholesterol. So between the the LDLs and also macrophages in the arterial wall will accumulate, and this chronic pattern leads to this plaque. It can start in childhood and is initially characterized by clinically silent arterial intimal plaques that grow. They become more complex for years and then decades. While atherosclerosis is developing in people, so most of us are going to have it, it becomes a really big deal when certain risk factors are present because that will accelerate the process and cause disease or death at an earlier age. Progression to critical vessel narrowing can be due to acute changes in the complex plaque that actually trigger thrombus formation and lead to severe stenosis or complete obstruction of an artery, and that can give us end organ damage and ischemia and death. Okay. You can also have atherosclerosis in our medium-sized arteries. Okay. So in the early stages of atherosclerosis, and this video, anosmosis, does a great job as well. Remember that the innermost lining of the vessel is the endothelial cells. So endothelial injury causes increased endothelial permeability. And this helps develop what we call a fatty streak. The endothelial cell injury initiates the process of endothelial permeability. That is then followed by the movement of LDLs into the intima. These events are promoted by elevated levels of LDL. So the greater your level of LDL, the greater the risk of more getting into the intima. And this causes sustained systemic inflammation. And that will lead to elevated CRP and tumor necrosis factor alpha, which are markers that you can check in the blood to help show if we're having possible disease processes like this. Okay. The upregulation of the endothelial adhesion molecules, right? So you're getting that sticking in there. That recruits monocytes to come to the intima, and then those monocytes differentiate into macrophages, and those macrophages are going to begin to phagocytose those LDLs. The plaque growth begins then when we keep recruiting additional inflammatory cells. So we will recruit T cells, dendritic cells, platelets, and mast cells. And those are in response to inflammatory signals such as these different cytokines. And this enhances more macrophages to come. And they'll continue to try to oxidize the LDL and phagocytize the macrophages. The cholesterol accumulation continues to swell the evolving lesion, and it gives it a fatty appearance, which is why we call it a fatty streak, but initially without encroachment on the vessel lumen. So this image in your book here does a nice job of helping us understand. So we're really early. Okay, this is our endothelial cells here. We have high LDLs, so here's the yellow LDLs coming in. We often are going to see increased CRP or decreased tumor necrosis factor alpha. Okay, as this is coming through the vessel here into the bloodstream, right? We don't have any narrowing yet. This is still kind of the length. Okay. So then that gets us to the next stage, which is more of the intermediate stage. So recruitment of the vascular smooth muscle cells now initiate the next phase. The vascular smooth muscle cells invade the intima and become activated to proliferate and produce an extracellular matrix, increasing the intima media thickness, which is the IMT. So now we're getting into here, where we're getting some of this smooth muscle things going on here. Okay. The VSM cells produce this fibric cap over the plaque, beneath which inflammatory interactions and cholesterol deposition continues. So it kind of gets sealed off, but underneath it continues to grow and to swell. Again, we haven't really significantly narrowed the lumen of our artery yet. After months or years of growth, many of the foam cells die and they leave behind cholesterol crystals and inflammatory debris. The necrotic plaque core is highly thrombogenic, but it's initially covered by, remember, that fibrous cap and the endothelial cells that keep the blood from coming in contact with it. So we have an atheroma, or a complex plaque stage, and we are now beginning to see the vascular lumen is beginning to narrow. You got these cells breaking through into here. We're continuing to get this, and we get a fibrous plaque here that's covering this area. So, but now you see we're beginning to narrow the lumen, and we're beginning to get decreased flow to go past there. Okay. Remember that the endothelial cells now that are overlying the plaque, these are highly dysfunctional, and they have diminished synthesis of nitric oxide and prostacyclin. So now remember, the endothelial cells are where we produce our nitric oxide, I cannot say that word, which is very important in our vascular health. But now we have an abnormal layer of that, so we do not have the appropriate production of the nitric oxide. We also don't have appropriate production of prostacyclin, which is something that comes into play. These factors cause vasodilation as well as inhibit platelet aggregation. Okay, so when you have, let me say that this way, when you have appropriate nitric oxide and prostacyclin, when it's done appropriately, they will help us do vasodilation, and they inhibit platelet aggregation. So when we have the endothelial cell wall working properly, we have normal nitric oxide, normal prostacyclin. This is good because this gives us the ability to have vasodilation. It also helps prevent the platelets from sticking together. So when you have this disruption in the endothelial cells and all these things are going wrong, now we've altered the synthesis of the nitric oxide and prostacyclin. And this sets the stage for thrombus formation, this outside part here. And as the plaque enlarges, our artery's own blood supply that supply the vascular wall may grow into the plaque, which is called neovascularization. The plaques can develop internal hemorrhages from these blood vessels, causing rapid expansion of the plaque. And now we get into some really big trouble. Now, depending on the size of the inflammatory core and the thickness of the fibrous cap, the plaques can be divided into what we call stable or unstable plaque categories. Stable or vulnerable. The vulnerable plaques are more likely to rupture, and that allows this thrombogenic lipid core, so this ruptures and it bursts into the bloodstream, and that can completely occlude the artery, giving us an infarction. Ruptured plaques can heal with fibrosis, but it will continue to lead to a very narrow lumen. Okay. So this is another way to look at it here. The initial stages of our plaque growth and the swelling of the intima is accompanied by an increase in the vessel outer diameter, right? Thus, the size of the vessel lumen is still preserved and the patient is asymptomatic. So this is minimal coronary artery disease. The patient can remain asymptomatic. However, this compensation is most effective only at mild to moderate stages, but as our lesion progresses, they include even greater percentages of the lumen. So our body can only compensate so long before it eventually overcomes. So this is the only area of blood flow. So this will lead to plaque growth and aneurysm formation. So a vascular aneurysm may develop just downstream from a large atherosclerotic plaque, and this is most common in our abdominal aorta, and that's because that's where the vascular wall blood supply is less developed compared to the thoracic aorta. Narrowing due to the atherosclerotic plaque changes our hemodynamic factors, and this will cause turbulent blood flow just behind the plaque. And as the vascular wall stretches, it weakens and an aneurysm starts to form, causing increased vascular diameter. But that leads to further changes in hemodynamic forces, and it actually increases wall tension, which in turn causes the aneurysm to progressively grow and eventually will rupture. So we're continuing to still talk about the same disease process of the atherosclerosis. So now we have to talk about the risk factors. We have these non-modifiable risk factors, which are the kind of, to me, the duh ones. We cannot change a patient's age, sex, ethnicity, or family history. We can help them improve on these risk factors to help decrease the formation of atherosclerosis. We can have other determinants of our risk factor for getting an pathophysiological changes of the atherosclerosis. Our endothelial vulnerability is very important, or preserving our endothelial function and to have it remain normal. When it becomes vulnerable because we've damaged it by high blood pressure, high blood sugars, smoking, high inflammatory mediators, over time we damage that endothelial cell, and that's going to become a big problem. Remember, anytime we're damaging or altering the endothelial cells, we are going to be messing with the nitric oxide. The nitric oxide is vital in maintaining our normal smooth muscle cell function and inhibit platelet adhesion. When you have healthy endothelial cells, they are impermeable, so our LDLs and other things cannot get in. Remember that normal endothelial cells are also smooth and present a surface that does not support adhesions of anything. But when you have those damaging forces, we have problems. Think of the shear stress, turbulent flow, smoking, inflammation, high blood sugars, high cholesterol. All of those things can damage our endothelial and cause activation of injury. Once the cells are activated, the endothelial barrier is breached, and now we have a big problem. Box 9.1 is a great box that I would spend some time reviewing and looking at because it really helps us break this down. That may be a really good box to have highlighted and to know to refer to for like test questions, because it really kind of simplifies what we've been talking about. The next thing that your book jumps into then is talking about this problems with our cholesterol. Dyslipidemia means any altered blood lipoprotein level. We typically think about the LDL as the big problem. LDL normally, we do need it. You do need some of it because it helps contribute to homeostasis. And it's the major source of cholesterol for tissues, such as steroid hormone. But an endothelial damage happens, and now the LDL molecules enter the vascular wall, and they become trapped there, and this whole process kicks off. So we know that one of the first steps is this LDL deposition, right? So if we can maintain healthy, normal levels of LDL, we are going to significantly reduce the amount that's going to be available to cause these problems into plaque formation. So our risk is of heart disease, of vascular disease, of atherosclerotic disease is going to be significantly greater with dyslipidemia, specifically high levels of LDL. Also, elevated triglycerides are not good. We also know that we need to have appropriate high density lipoprotein, the LDL, right? But we can have this genetic disorder, the familial hypercholesterolemia. This is crappy because people that have this, they cannot control. Everything's kind of gone wrong because they have this autosomal autosomal dominant trait. And it's this mutation of the LDL receptor, and it causes you to have chronically high LDL levels. We now know that it is a related genetic defect with a gain of function mutation of the PCSK9, and this decreases the LDL receptor expression and increases your risk of cardiovascular disease. So these patients can do really well with this new drug class of the PCSK9 inhibitors. Also, those are good for people that cannot get their cholesterol controlled with statins. So bottom line, it is very important to target these modifiable things that we can modify to reduce our risk. As one of the main things is smoking cessation, right? We know now that smoking increases oxidative stress and vascular constriction and more inflammation of the vascular wall. We know that high blood pressure causes changes in the hydrostatic pressure and the shear stress, and things change, and this predisposes the endothelial cells to injury, which makes them a perfect candidate to start the atherosclerotic process. So high blood pressure is a contributor to atherosclerosis. We know that type 2 diabetes is a big problem as well because, number one, typically hyperglycemia is associated with dyslipidemia. They tend to go together. But chronically elevated glucose levels also contribute to abnormal glycosylation of the circulating tissues and proteins. This is a problem because this causes increased inflammation and abnormal tissue function, and all of that plays into the damage of the endothelial cells. So we need to have people stop smoking. They need to exercise. They need to have a good diet. They need to get sufficient sleep, control their blood pressure, control their cholesterol, control their glucose, and maintain a healthy BMI. Your book does talk a little bit more about familial hypercholesterolemia that we talked about there. There's some things in the book that you can read on if you need more information about that. Okay, so we've started talking about atherosclerosis and aneurysm. Those were our large artery diseases or medium artery diseases. Now we're getting into the peripheral arterial disease. So mainly we are talking about the lower body, large and medium-sized arteries. Okay. This is a disease that is caused by stenosis or occlusion of these arteries, typically due to atherosclerosis. Atherosclerosis is the leading cause of peripheral arterial disease in patients older than 40. Most people have it in their 6th and 7th decade of life. Most patients are asymptomatic for a long time. Some can have a slow or impaired gait. The most classic, quote-unquote, sign of PAD is what we call claudication, which is intermittent. It comes and goes. You get a pain, ache, cramp, or fatigue in muscles after or during exercise, but when you rest them, it goes away. This typically is telling us that when you have high areas of demand, you're walking, you're exercising, because you have stenosis, you can't supply the adequate blood supply to the muscles, and they cramp and they ache and it hurts. But once you rest and you decrease your demand, more blood flow can get there and oxygenate the muscle again, and now the pain goes away. We use ankle brachial indexes as a means to check for this as well. Okay. Branching at the femoral and popliteal arteries are common sites for this plaque, and other common sites can be the iliac, tibial, and peroneal arteries. The worst case scenario is obviously that you may have to amputate if you lose the blood flow completely and get critical limb ischemia. Problem. Your book also, I wanted to point out, does talk about the ABIs, and those are good to understand. You're getting the ankle brachial index. So you're getting bilateral measurements of your systolic blood pressure while the person is lying supine. Okay. You get brachial systolic pressure from both the right and the left arm, and you take the highest systolic pressure. Okay. Then you get ankle systolic pressure, so you're measuring their blood pressure around their ankle. And you take the highest value from the right and left sides. Then you calculate them. Anything less than 0.9 is suggestive of peripheral arterial disease, so 0.9 or above is normal. If you have less than 0.5, you probably have pretty severe stenosis, and it's a critical problem. All right, we've moved from the large and medium down into the arterioles, right? So the next section of vascular system. So let's talk about that, the properties and disorders associated with this system now. The arterioles provide resistance to support blood pressure while regulating blood flow to the tissues. The pressure inside each segment serves a physiologic purpose, and it's maintained within a relatively narrow range. So we really need to have normal arterial pressure for driving the blood flow through these narrow vessels and ensuring that we get the blood all the way to the end to the organs. When we are upright, we create a gravitational pull on the columns of blood held within the vascular system, such that the vascular pressures are higher below the heart and lower above it because of gravity. A constant supply of oxygen and blood flow is needed to the brain, right? So our arterial pressure ensures adequate blood flow while standing. For that reason, our arteriolar resistance, limiting outflow and maintaining arterial pressure, is central when we're in an upright position to be able to be conscious and get adequate blood flow to the brain. So when we're talking about the arterioles, we've gone from the large arteries, the mediums, to the small, and now we're at the arterioles. The arterioles have a relatively small diameter, but a relatively thick wall. That looked wrong to me. Small diameter, thin wall is the arterioles. They have the media, the intima, the media, and the adventitia. Okay. The media consists of 2 to 3 layers of our vascular smooth muscle cells. This in the arterioles, our media is highly responsive to local factors, synthetic neurotransmission, and circulating mediators. At the arterioles, we are very capable of rapid changes based on needs. They are meant to sustain arterial blood pressure for blood flow against gravity to the brain and regulate flow to the tissues as required for tissue activity and to maintain homeostasis. Okay. Next, we're going to talk about blood pressure and how we actually determine blood pressure and what it is we're even looking at. Okay. When we talk about a MAP, or the MAP, the mean arterial pressure, it's the hot number in sepsis and all those things, right? Like we have to maintain a MAP above 60 or 65. And understanding that the MAP is the average driving pressure within our circulatory system. So we know the formula for MAP is the diastolic blood pressure plus systolic blood pressure minus diastolic blood pressure divided by 3. My mother, who's in her 70s, is a retired nurse as well, and she still remembers that formula because she did it for many, many years of her career, calculating it herself. Okay, the book does go into Ohm's law. We're not going to spend a lot of time on that by any means. We do need to talk a little bit about the vascular resistance and the flow and some of these things, right? So the book talks about this, that flow equals pressure divided by resistance. Okay. Technically, the pressure gradient driving flow within our systemic circulation is our mean arterial pressure minus our central venous pressure. Okay, but we don't usually mess with central venous pressure much. Okay. Our mean arterial pressure can also be determined essentially by our cardiac output times our total peripheral resistance. So that's kind of a rearrangement of some of the ideas of how you could calculate or think about what we're talking about. Peripheral resistance is regulated locally and systemically through regulation of our vascular smooth muscle contraction or dilation by certain key mediators. Okay, we'll kind of come back to that idea. We have a pulsatile blood flow problem. We know that our highest pressure is generated during systole when we have cardiac ejection of the blood from the squeeze of the left ventricle. And we know that we would have the lowest pressure immediately before the aortic valve opens at the very end of diastole. The mean arterial pressure is closer to diastolic. Okay. As you can see that here, this is a diastolic 120/80, but our mean tends to be closer actually to the diastolic number than the systolic number. We do have this wave here that shows the peak and trough, but we have this dichrotic notch here. And this is indicative of a brief increase of pressure when the aortic valve closes and the pressure rebounds against that closed valve. We kind of get this from that happening. At our resting heart rate, about 1/3 of the time is spent in systole, and 2/3 of our time is spent in diastole. Systolic pressure is influenced by our stroke volume and pressure, and by properties of the aorta and large arteries. Okay. This here is talking about total peripheral resistance and how it hinders the blood flow from the left ventricle and is one of the major determinants of blood pressure. So we are saying that our blood pressure is our pressure we need, the amount of force we need to overcome total peripheral resistance, to get that blood flow to move down past that resistance. We have to have enough pressure. Okay, that's essentially what we're measuring in blood pressure. So our total peripheral resistance very much is a key player in our blood pressure measurements. Okay, so we have a couple of things that are at play of our blood pressure. Okay, to determine our blood pressure, our body needs to create enough pressure to overcome the peripheral resistance, but we also need arterial compliance and arterial elastic recoil in order to have appropriate blood pressure. So our arterial system here during systole is being shown here. So systole is up top here. Okay, during systole, we need to be able to have that to be able to be compliant enough to stretch outward, right? So it stretches to allow the blood to be able to, that volume to come through. If we have a very stiff wall, we're going to have greater peak pressures. We also need to have our arterial elastic recoil to maintain our pressure during diastole so that the blood will continue to go. Peripheral resistance influences diastolic blood pressure. So our systolic blood pressure is the measurement of how much pressure we need to create to move the blood out of the left ventricle into the arterial system. So how much resistance we have down the flow, how much resistance is there is going to create our blood pressure. If we have high resistance, we have high blood pressure. High resistance means what? So if we go back to the equations of Laplace and go through all of that stuff, right? So let's think about this. I need to create blood pressure to overcome my resistance, okay? Part of the resistance is tension, right? So the Laplace and this artery rule, if you will, is going to play into our blood pressure. Okay, so if I have a ton of pressure and I get those stiff walls and I get hypertrophy, right? I'm going to have to continue to have greater blood pressures because I'm creating more resistance. So as I am trying to think about this, as you're having this pressure come down this hose, if the hose is very narrowed, the wall is too thick and it can't expand to hold that blood volume. I'm going to have to create a whole lot of pressure to force that blood down that hose to get all the way to the end. So things like my total peripheral resistance or my total vascular resistance is going to affect my blood pressure. If I have high resistance in the arterial system, I'm going to need high blood pressure to overcome. I can get high resistance because I've lost tension, or I've created too much tension, or I've lost compliance. I've created vascular hypertrophy, and now I don't have elastic recoil, or I don't have arterial compliance. All of those things are going to increase the resistance. And I have to increase my blood pressure to overcome that, to get the blood flow to work the way it needs to down the line. Okay. I still need pressure within my system at the end of diastole so that I continue to have tension to keep the circulatory system open for that brief period of time of diastole. So my diastolic blood pressure is the pressure at the end that's left over, that is created there at the end. So I would have like 80 milligrams of mercury pressure left. That's still keeping that open from the pressure of the end of diastole. Okay. So this will come into play a little bit here as we talk about the big picture. So our heart generates our cardiac output to pump into our large arteries that diverge into smaller arteries, diverge into the arterioles, and get all the way down to the capillaries. As we get down into the smaller things, we tend to have higher resistance. The mean arterial pressure is generated as blood flow encounters these small diameter vessels, maintaining high pressure in our large arteries. Okay, so MAP, our mean arterial pressure, is our total cardiac output times how much resistance. So the mean arterial pressure, so that one between systole and diastole, the average mean arterial pressures is going to be measured by our resistance and our cardiac. All right, so let's talk about how do we determine vascular resistance. Lots of formulas here. Your osmosis videos covers this as well. This equation talks about F is flow. So we need to determine our flow, which is our pressure difference between the two ends of the tube, the viscosity of the blood, the radius of the tube, and the length of the tube. Okay. They rearrange that all to show that resistance equals all of those humble mumble bumbles there. So the main purpose, though, of this is that the primary determinants of our vascular resistance are the length of the blood vessel. Once you're grown, that should not change much. The viscosity of the blood. So if you're anemic, if you have too much hemoglobin or too little hemoglobin, or too many red cells or too little red cells, can change your blood viscosity. But typically, when we're in normal red cell range, we have a stable viscosity. And then the radius of the vessel is the main factor then that controls vascular resistance on a minute-to-minute basis. Remember that this looks like the resistance is related to the radius raised to the fourth power. So even small changes in our vascular radius translate to large changes in resistance. Okay? Meaning that if we increase the radius, even a skosh, we can drop the resistance quite a bit. So in other words, vasodilation can be very effective in decreasing resistance, right? So if I have a mean arterial pressure, which is our cardiac output times our resistance, and I give a vasodilator, and I decrease my total peripheral resistance, I'm going to decrease my MAP. Or if I give a drug to increase, to cause vasoconstriction, okay, and I'm going to change the radius and squeeze down, I'm going to increase the pressure. So now my MAP, my TPR goes up. So now my cardiac output times a higher number is going to give me a higher blood pressure. So when we use vasoconstriction drugs or vasodilating drugs, we don't have to do huge changes to affect the radius. So those small changes to the radius can cause huge changes in resistance, is what we're getting at here. Okay. The next thing to remember is that blood pressure is pulsatile. We talked about that. Pressure changes are smaller in the aorta because the elastic recoil of the aorta and large arteries help to maintain our diastolic pressure and blood flow. Pulse pressure is, remember, that's systolic blood pressure minus diastolic. So the differences between systole and diastole pressures. Our pulse pressure increases slightly in large arteries, and it will decrease in small arteries. The greatest change in our mean arterial pressure and our pulse pressure will occur at the arterioles because they represent the greatest amount of resistance within our systemic circulation. At the level of the capillaries, pulsations are gone, and the pressure just continues to drop. Which is what we're seeing here. By the time we drop down past into the capillaries, we get this biggest pressure drop. And then when we're getting into the veins, our pressures are very low in the venous system. Because most of our vascular resistance is at the levels of the arterioles, these vascular segments are in a unique position then to regulate blood pressure both in the arteries and the capillaries, which is what they're showing here. So the boot is hovering over our arterioles. So our flow is continuous from our heart down the path to our veins. The normal pressure drop across these arterioles leaves sufficient enough capillary pressure to function and do adequate tissue exchange. If we were to cause constriction in the arteriolar area, that is definitely going to increase our blood pressure, because now we need a lot of pressure at this faucet to overcome this kink down the flow. It reduces our pressure and flow in the capillaries and veins. So increasing arterial resistance by this constriction will increase the pressure in the arteries up here, but decrease down here. So in this scenario, the arterial pressure increase due to the increase in vascular resistance is present, while capillary pressure decreases, because increased arterial resistance causes a greater pressure drop at the level of the arterioles. That's a good image for us here. Under our normal circumstances, arteriolar resistance is regulated by local and systemic factors that balance our metabolic demands. Shifts of flow between the vascular beds and the changes of cardiac output can adapt cardiovascular function to our changing needs. Global changes in flow come into play during intense exercise or intense fight or flight, because the cardiac output can increase up to 5 times the normal rate. Muscle and cardiac flow can increase 4 to 5 times, and we maintain our normal blood flow to the brain. Under pathological conditions, though, like hypertension, arteriolar resistance may be too high, causing this elevated blood pressure and the potential also for reduced tissue perfusion down the flow. But in contrast, in things like shock, we get a decreased arteriolar resistance, and that can cause a dangerous decrease in our arterial blood pressure and the potential loss of fluid into the tissues due to increased capillary pressure and flow. Okay. Which is what they're talking about here. So how do we regulate our blood pressure is obviously a huge thing for us to understand as practitioners, because we will be messing with blood pressure all the time. And so we have short and long-term regulation issues, right? So in an immediate crisis, if someone's sick, we're talking about, short acting things, but over long-term is then kind of lifestyle type situations. Short-term control of blood pressure is accomplished by our baroreceptors and our baroreceptor reflex. This is a neural mechanism relaying the signal of increased or decreased blood pressure to our brainstem. Okay. And that helps us to appropriately adjust our parasympathetic or sympathetic cardiovascular outflow. So our baroreceptors are signals that go to the brainstem. So they will be triggered, if you will, for both low or high blood pressures. And that allows our brain then to send adjustments to our parasympathetic and our sympathetic systems to help adjust accordingly. With long-term control of blood pressure over hours and days or weeks and years, that is accomplished by the sensors that detect circulating blood volume and blood pressure, and they adjust the fluid intake and renal fluid excretion to alter the body fluid. That is also known as adjusting the kidney and endocrine mechanisms like our renin, angiotensin, aldosterone system. Okay. So in the short term, if our baroreceptors are triggered because we have low or high blood pressure, okay, They can help change our total peripheral resistance to increase our arterial pressure, or they can change and manipulate our total cardiac output to change our arterial pressure. Let's talk a little bit about these terms again. When we're talking neural, N-E-U-R-A-L, those are baroreceptor reflexes by the autonomic nervous system. When we're talking about humoral, we're talking about humoral system is circulating mediators like our angiotensin II or vasopressin. And then we use the words local mediators, which is, again, here's the word, nitric oxide, also bradykinin, endothelin, and prostaglandins. So all of these mechanisms can alter vascular resistance by changing arteriolar diameter and cardiac output by changing heart rate, contractility, and preload. The long-term mechanisms are primarily endocrine, and those include our hormones that affect our fluid balance, like aldosterone, vasopressin, and our natriuretic peptides. Okay. Those mechanisms alter our blood volume. Actually, while I'm doing this, I'm going to add this. Added slide. Okay, so the blood pressure is regulated at the 4 anatomical sites. We can have our resistance in our arterioles. Arterioles represent the primary site of vascular resistance that help maintain our normal blood pressure. Remember, if we alter the radius at the arterioles, we can very much affect our vascular resistance. So our radius is regulated by intrinsic mechanisms, including our action potential activity that opens our calcium channels, right? We have extrinsic regulation by our neural, humoral, vasoconstrictor, and vasodilator substances. And then also we can use antihypertensive drugs that are going to work at the vascular smooth muscle of the arterioles. Okay. Blood pressure is also regulated by the capacitance of our venules. So the veins and venules will alter cardiac output and therefore blood pressure by regulating venous return, right? So how much of the blood that comes back to the right atrium. Normally, in normal states of health, the veins and the venules store a substantial portion of our blood volume. Remember, we called that capacitance function. But during times of hypotension or hypovolemia, our sympathetic nervous system is going to be activated to stimulate venoconstriction, increasing our preload to restore our cardiac output. Blood pressure is regulated by our cardiac output or our heart pump output. So cardiac output is our heart rate times the stroke volume. So increasing our heart rate or the stroke volume will increase our cardiac output, thereby increasing our blood pressure. And then our kidney regulation plays a major role in blood pressure because the blood volume is highly regulated by the kidneys. And so if we affect our blood volume, we affect our blood pressure. You may hear us talking about the idea of vascular tone. If you've ever heard that, really what they're talking about is vascular smooth muscle. And actually our vascular smooth muscle is in a constant state of moderate contraction, and meaning we have good vascular tone. Due to intrinsic vascular smooth muscle properties, we should always have good vascular tone. Your book talks quite a bit about how we maintain our vascular smooth muscle tone. In summary, there's a basal state of vascular and sympathetically supported vasoconstriction that helps maintain our arterial pressures. Remember that we can have short-term homeostasis of blood pressure changes by increasing and decreasing our sympathetic nervous system. And the vasoconstrictor activity in order to meet the demands of our body, right? So you guys can read through those chapters there if you need more information about that. Or not chapters, these are paragraphs. The regulation of resistance can also be can be organ specific. Autoregulation keeps our brain, our heart, and our kidney blood flow constant, despite we can have varying changes in our blood pressure systemically. But we know we have to preserve these vital organs and we have to maintain kidney filtration. So autoregulation is very important. We do that without thinking, right? Our body just knows to do that. And there's two mechanisms for autoregulation, as you can see here, the myogenic and the metabolic hypothesis. In the myogenic one, the sudden increase in perfusion pressure stretches vessels open, and so our vascular smooth muscle responds by contracting more tightly. Metabolic hypothesis is the decrease of flow causes buildup of our vasodilator metabolites, and we relax our vascular smooth muscle to increase flow. The organs with our highest degree of our autoregulation is the kidneys and the brain, and they have additional tissue-specific mechanisms directly working to maintain a relative constant flow despite our varying blood pressure changes, which is what we can see here. When autoregulation is present, a decrease in pressure is compensated for by a decrease in resistance, which will restore the flow relative to the condition, whereas a system with autoregulation can vary between dilated vessels or constricted vessels to help maintain the constant flow despite altered perfusion pressures. This one here is showing the myogenic metabolic tissue specific changes that we can do. Not going to go into a lot of that. So at the cellular level, we can have changes that will change arteriolar resistance. You guys already learned this in chapter 4 of the cell physiology when we talked about smooth muscle contraction. We know in order for this to work, we have to have calcium homodulin, myosin light chain kinase. Relaxation requires the myosin light chain phosphatase. We have the G protein coupled receptors that influence our vascular smooth muscle. In other words, the G proteins are linked to these different receptors that can cause relaxation or contraction. Don't get caught up memorizing G, or GS and links to this or that. The general idea is what we're going for here. The table 9.2 does a great job of helping us put into a table the mediators and the mechanisms that regulate our vascular resistance nicely there. What I like is that it'll say the vascular effect and which mediator, and then the type of regulation. So the first two columns and the last column. So if we want a vascular effect that causes constriction to increase our resistance, we can work with the mediator norepinephrine or angiotensin 2, right? So if I wanted to say I want to increase my increase my resistance, my vascular resistance through neural regulation, I know I'm talking about the mediator norepinephrine. If you wanted to increase your resistance through a paracrine mediator, we would say thromboxane A2. If I wanted to increase resistance and cause constriction with an endocrine regulator, maybe I would talk about angiotensin 2, right? So it's helping us show the different mediators and the mechanisms that cause the change in the vascular resistance. But maybe I want to cause decreased resistance with vascular dilation. Well, if I wanted to do that with a paracrine regulator, I could be adjusting prostacyclin or my atrial natriuretic peptide, or the mediator my body may work with, etc. So the sympathetic nervous system will adjust norepinephrine, which causes the tonic vasoconstriction. We can manipulate the RAAS with changes in our angiotensin 2 or aldosterone. Vasopressin works, adrenal epinephrine, cardiac natriuretic peptides, endothelial mediators like our nitric oxide, prostacyclin, which is what we need to dilate, and endothelin, which is what we use to constrict. Inflammatory mediators also can cause local vasodilation when we manipulate histamine or prostaglandins in our body. Okay. I would take the time to pay attention to your book on page 303 when it talks about the 5 key mediators to help regulate our vascular smooth muscle contraction and to regulate our arteriolar resistance. Okay. So the top 5: norepinephrine, the renin-angiotensin-aldosterone system, vasopressin, epinephrine, and the natriuretic peptides. These are listed then on the page 303, and I think they are really lovely definitions, and you will talk about these again in in pharmacology. So understanding this now is great for you to help you in the future. All right. The book then jumps into talking about the RAAS system. And again, these this concept's very important because when we give drugs like an ACE inhibitor or an angiotensin receptor blocker, an ARB, we are manipulating this RAAS system to control blood pressure, right? So our body also has ways to regulate using this system as well. Low blood pressure can be detected by our juxtaglomerular apparatus of the nephron, just here. So it gets the signal that, our MAP is decreased, right? Our blood pressure is going low. We have a problem. Renin is secreted by the granular cells in the walls of afferent arterioles, which is what we have here. Then we get the renin. Renin is an enzyme that cleaves the precursor protein angiotensinogen, releasing the decapeptide angiotensin 1. So it cleaves this off and we get angiotensin 1. Angiotensin 1 circulates through the systemic and pulmonary circulations and then is, right, so here in lung and our whole systemic circulation. And it's converted then to angiotensin 2 by the angiotensin converting enzyme, which is ACE, which is particularly abundant in the lungs. Angiotensin 2 is a vasoconstrictor at the vascular AT1 receptors and is also the key regulator of adrenal aldosterone secretion. Okay. Aldosterone is the final mediator of the RAAS, which stimulates sodium conservation through its actions on the distal nephron. So, all of this happens and we get the brain is going to receive a signal to make us thirsty, so we drink more. The adrenal cortex is going to be stimulated then to have aldosterone secretion to tell us to conserve sodium, to increase our fluid volume. It's going to tell the body to do vasoconstriction systemically, just to increase our blood pressure. It's going to tell the kidneys to start retaining sodium and water. And it's also going to trigger inotropism, which is an increase in our heart rate. So, with all of that being said, our kidneys get a signal that the mean arterial pressure is dropped. It sends out renin. Renin will cleave off angiotensinogen to angiotensin 1, which goes to the lungs and the whole systemic circulation. The lungs are very rich in ACE through this. So then this ACE is going to convert the angiotensin 1 to 2. And with 2, all of these effects are going to happen, including making us thirsty, causing our kidneys to retain sodium and water, and causing our heart rate to go up as a mechanism to control our blood pressure. So this is showing us a local mechanism of vascular smooth muscle control. Okay, so locally within the certain regions, what are we going to do to alter our blood pressure? The vascular smooth muscle cells intrinsically will respond to stretch. So if you have an increased blood pressure or blood volume by contraction, the myogenic mechanism, they will respond. And this will help regulate our renal blood flow and maintain glomerular filtration rate. Okay. Also, endothelium-derived mediators will be playing a vital role in our vascular smooth muscle regulation. Okay. The primary endothelium-derived mediators are the potent vasodilators of nitric oxide and prostacyclin and vasoconstrictor endothelial 1, which is ET1. Okay, we're going to talk about this again. So, nitric oxide is produced with the endothelium, and it is essential for maintaining our normal blood flow during our normal health. Nitric oxide is produced in the endothelial cells by the endothelial nitric oxide synthase, which is in response to the shear stress from our blood flow and receptor stimulation. Remember that these G protein coupled receptors increase the activation of nitric oxide synthase, which produces the nitric oxide gas from amino acid precursor, the L-arginine. Nitric oxide diffuses out of the endothelial cells to the underlying smooth muscle, and that will cause relaxation. Endothelial dysfunction, which is common in diabetes, hypertension, and atherosclerosis, will cause a decreased nitric oxide production, and that will contribute to further vascular pathology. So when we can get the appropriate nitric oxide process here, we can get the normal vascular muscle to relax. If I cannot produce enough nitric oxide effectively, I will not get relaxation, and that will promote stiff vascular problems, right? All right, so in summary, arteriolar resistance is determined by a balance of local and systemic vasodilator and vasoconstrictor influences. Our arterioles serve a dual role because they will regulate our systemic blood pressure, or our MAP, by regulating peripheral resistance, but they will also regulate blood flow to our individual organs according to organ oxygen demand. When we have changes in arteriolar resistance, we will have opposite changes in our MAP and capillary pressure. This regulatory system continuously weighs the whole body's needs against the metabolic demands of the individual tissues and organs. So this image here is showing us the vascular smooth muscle cells will integrate many signals. Calcium entry through the L-type calcium channels will stimulate VSM contraction, which is also modulated by several types of G protein coupled receptors. The agents that can increase our intracellular calcium promote vasoconstriction, while increased cyclic nucleotides like CAMP or cGMP promote vasodilation. Long-term changes in VSM gene expression account for the development of hypertrophy in the context of hypertension and vascular disease. Really busy image here, but it kind of helps put in perspective all of these things are happening at the endothelial cells that are going to contribute to our vascular function, which is going to be what helps change and maintain our blood pressure. And the book actually says, with so many mediators that influence the vascular smooth muscle contraction, most of which have low blood levels at all times, how do the smooth muscle cells put all of these signals together to maintain blood pressure? And it's table 9.3 in your book, which again does a fantastic job to show you in summary that these contributions and summarize the mediators that have work well with them. So table 9.3 is also a great table to have flagged. That's on page 308. Okay, going a little bit deeper, baroreflexes and our circulatory control. So our baroreflexes, remember, we're doing short-term BP changes with that. When we can sense high pressure stretch, we have these detectors in our carotid sinus and aortic arch. And those ones will be triggered. They'll be like, uh-oh, we have a large volume causing a big stretch coming in. And the sensory fibers will relay to the medullary nucleus of the solitary tract. We have a multisynaptic pathway which control our autonomic response. We have the vagus nerve to the heart and the sympathetic nerves to the heart. Okay? So this will all work together. So our sensors in the carotid sinus and the aortic notch will notice increase and decrease in our distension. Okay. Increased pressure stretches the sensory endings, increasing their action potential firing rates, whereas the decreased pressure relaxes the stretch on the sensory endings and will decrease their action potential, right? So this is kind of helping us see this here. The the fibers that we're talking about will terminate in the nucleus of the tractus solitarius, which is abbreviated NTS, which is in the medulla. So this is our brain stem here, and this is that NTS. Okay, so we have these baroreceptor reflexes here that are going to sense that this has changed, right? And it's going to send this along this sensory pathway to this nucleus of the tractus solitarius in the medulla. Abrupt increases of arterial pressure increase our baroreceptor sensory fiber activity. That stimulates this NTS neurons, and that will project to the parasympathetic nucleus, resulting in rapid compensation by increased vagal outflow that will slow the heart rate. It will decrease the firing of the spinal cord sympathetic neurons that regulate vasoconstriction. And that combination of a decreased heart rate, which will therefore also decrease cardiac output, and the decreased sympathetic vasoconstriction, which will decrease our peripheral vascular resistance. This will be what can return our blood pressure back to normal. If we have a sudden decrease in our arterial pressure, it's also going to use this circuit. Okay. So it's going to sense the decreased arterial pressure. It's going to decrease the baroreceptor firing. This causes a decrease in the NTS stimulation. This will cause a decrease in our vagal stimulation. But at the same time, it's also going to increase our sympathetic stimulation. And by doing that, we're going to get an increased heart rate, increased contractility, increased vasoconstriction. The heart rate and the contractility are going to increase our cardiac output. When we increase our vasoconstriction, we increase our total peripheral resistance. And remember that our MAP is our cardiac output times our TPR. So when we increase this variable and we increase this variable, we're going to increase our blood pressure. Okay. The decreasing of the vagal stimulus also increases our heart rate. So we can increase our heart rate by two pathways there. One of the most important things about this is that the baroreceptor reflex is important in our beat-to-beat regulation of blood pressure. And that is what prevents us to have orthostatic hypotension when we move from a supine to a sitting position. Our homeostatic system is responsible for this short-term compensation for our altered blood pressure. The bad thing is that if we have long-term exposure to high blood pressure, our body tries to compensate by actually having our baroreceptor fibers be reset to a new level of blood pressure so that we're not constantly doing the long-term mechanism, which is a bad thing because we just keep going up and up and up on our blood pressure. So how do we get hypertension if we have these built-in compensatory mechanisms, right? Well, it happens by two mechanisms. We get direct stimulation of the vascular smooth muscle contraction, which is going to increase our peripheral resistance. And we get increasing body sodium and water content through the actions of the kidneys and other tissues. So an increase in sodium and water retention will increase blood volume filling the circulatory system, which will increase our blood pressure. Secretion of these hormones is controlled by both high pressure arterial baroreceptors, again in our carotid sinus and our aortic notch, and the low pressure and low volume receptors in our atria, ventricles, and pulmonary arteries. We also have intrarenal baroreceptors in the juxtaglomerular apparatus that will then alter or regulate our renin release. So, primary or essential hypertension is the most common cause. And actually, I love that the book says this, we still don't really always truly understand the pathophysiology yet. But again, we have these two hypotheses that we get this change in our renal sodium and water retention, and we get chronic sympathetic hyperactivity, which will cause a chronic vasoconstriction. We do know that risk factors such as your family history are at play. People with certain race and ethnicities have higher risk. People who smoke, are obese, diabetes, and hyperlipidemia are all going to have increased risk for hypertension. And if we go back to the big picture that we talked about before, hypertension can lead to vascular hypertrophy, which is going to change and alter the tension and the flow and all those things, which disrupts the endothelial cells, which then also causes atherosclerosis, etc., etc. Also, it changes the vascular hypertrophy of the vessel, which can lead to aneurysms. The interesting thing is that the cardiac output is typically normal, even in high blood pressure, like chronic hypertension. And that's what implicates the chronic increase in our vasoconstriction, or the chronic increase in our total peripheral resistance. There is a form of hypertension called the secondary hypertension. It's only about 5 to 10% of patients, but we can treat something else and help their blood pressure resolve. One of the big ones is kidney failure. The other one is endocrine issues like excessive hormones that stimulate the cardiac output, or peripheral resistance, or both. So we think hyperaldosteronism, hyperthyroidism, a pheochromocytoma, or hypercortisolism can be issues. Going back to our theories on hypertension and potential contributing factors. Remember, these are kind of still hypothetical. So one says that there's an initial defect in sodium and water retention that will ultimately increase our vascular volume and our cardiac output. And you can see that through this here. Over time, the cardiovascular system achieves a new steady state with normal cardiac output but higher vascular resistance maintained by increased tone and hypertrophy of the vascular smooth muscles. Okay. So with our increased sodium intake, we will have sodium retention, and sodium excretion could be altered, which will lead to increased blood volume, which will increase our cardiac output. The sodium intake causes this here. Then with our sympathetic nervous system, it will increase our contractile force. The renin-aldosterone, angiotensin-aldosterone system messes with this, the vasoactive agents and vascular remodeling. And at the end of the day, we get cardiac output is greater and peripheral vascular resistance can be greater, and that's going to make your blood pressure higher. At the time of diagnosis of mild hypertension, the usual presentation will show a normal heart rate and a normal cardiac output. Can even show normal sodium and water balances. So that means that the increased vascular resistance is likely the initial cause of the elevated blood pressure. It appears as if a physiological set point for systemic regulatory activities has been simply shifted to a higher pressure. Because the basis for the elevated pressures cannot be identified, our treatment still focuses on reducing blood pressure to normal levels through lifestyle changes and medication. Hypertension for some cannot be cured, and so lifelong modifications or medications may be necessary. When we have chronic hypertension, we have problems. Number one, we get the baroreceptors to be reset, so they don't respond to elevated BP anymore, and we've lost our compensatory mechanisms. We know that the vascular smooth muscle cells undergo hyperplasia and hypertrophy. They get thicker, they get stiffer, we lose our compliance, and this will lead to troubles, especially though at the arteriolar level. So our renal arterioles really are sensitive to this, and that can predispose chronic hypertension people to kidney problems. Our blood vessels in our brain have increased atherosclerosis, aneurysm formation, and potential rupture, right? Or atherosclerosis and stroke. The coronary arteries have increased atherosclerosis, increased cardiac oxygen demand, and that will be done or be increased due to the ventricular hypertrophy and workload. Hypertension is one of the most common causes of heart failure, and early and moderate hypertension is asymptomatic or silent until the damage to all of these organs accumulates. The brain is quite sensitive to blood pressure variation, so hypertension can affect our cerebral circulation, but we also think that cognitive decline is accelerated by hypertension. Table 9.5 is a beautiful, quick table of the complication and the contributing factor that we've talked about, complications of hypertension and why that is. It's a really nice table. Talking about how are we going to treat high blood pressure is a very complicated thing, and it needs to be multifactorial. You have to have dietary and lifestyle changes. You have to typically use these drugs that will target different areas. So we use drugs that target cardiac output, target vasoconstriction, target our blood volume, or target our calcium entry into the heart or the vascular smooth muscles. We will talk a lot about this when we get to pharmacology. So the book adds shock in this section because shock is a result of decreased blood pressure or decreased peripheral resistance. So it goes into the vascular section. Shock is a state of severely decreased perfusion, pressure, and blood flow that greatly reduces tissue oxygenation. If this state is not quickly corrected, we will get irreversible damage and death. Okay. So there are different types of shock that we're going to go through. They can cause syncope, organ problems, death. They can be caused by massive trauma or burns, blood loss, spinal cord injury, heart failure, anaphylaxis, or sepsis, generalized loss of vascular resistance, or loss of blood volume, blood pressure. We try to do early changes to fix it. Our body does. So we have early autonomic and endocrine compensation. So we try to change things quickly to get tachycardia and vasoconstriction to support our blood pressure. If treatment is inadequate, you will decompensate and die. So the first type of shock that they talk about is hypovolemic shock, and this is mainly hemorrhagic. It can be severe dehydration, but those are some pretty extreme cases. Usually I think of hypovolemic shock with hemorrhage. Okay. The primary problem is you don't have enough circulating volume, right? So you're going to see a decrease in preload, a decrease in our cardiac output. Our body's going to try to increase our total peripheral resistance. Okay, so we try to compensate initially by increasing our vascular resistance to get vasoconstriction. We have to treat it with blood and fluid replacement. If we don't, we're going to die, right? How someone bleeds to death. Distributive shock is what we consider sepsis. This is because with sepsis, we get a series of things that lead up to a massive vasodilation. And so our blood volume is initially normal, but this massive vasodilation reduces our peripheral resistance, which abruptly drops the blood pressure. Okay. Distributive shock also can include anaphylactic and neurogenic. But septic shock is one that we see typically in hospital settings. The distinctive aspect across all forms, though, of distributive shock, which is different than the hypovolemic or cardiogenic or obstructive, is that with distributive shock, there's an ability to compensate by vasoconstriction and increased peripheral resistance. Anaphylactic shock is terrible because we get this massive histamine release, which causes this massive blood pooling and widespread, profound vasodilation. Neurogenic shock is a result of typically a spinal cord injury, or when there's a complete cessation of firing of our vasoconstrictor sympathetic neurons. This also could be a drug overdose or spinal anesthesia, but typically it's a spinal issue. And all of those have the potential to interrupt that spinal sympathetic outflow. And with the withdrawal of the sympathetic nervous system tone, the vessels dilate and we get peripheral resistance to drop precipitously, and the blood pressure just tanks. Then you get the loss of the brainstem stimulation of the sympathetic tone, and that will prevent the baroreflex of the heart rate and increased cardiac contractility. All right, cardiogenic shock. This is when you get a significant reduction in cardiac output. One of the main reasons for this is a heart attack. But because your cardiac contractility being reduced is what precipitates this event, your CVP becomes elevated, but your cardiac output remains normal. And you cannot improve significantly by volume expansion, and you can get actual pulmonary edema with too much volume expansion. So the focus for treating cardiogenic shock is to restore cardiac contractility as quickly as possible. This is what we get with like intra-arterial balloon pumps, LVADs, the Impala, and then basic management with inotropes. Last form of shock, my lord, is the obstructive shock. So this is any disease condition that reduces cardiac filling or obstructs the blood flow, will critically reduce the cardiac output and blood pressure. This would be like restrictive pericarditis or pericardial tamponade, or even pulmonary emboli or attention pneumo, because you severely reduce the lung blood flow. You've made it through the 2 hours of part 1. We'll see you in part 2.